A suspect case is any person with an acute respiratory illness, that is, fever, cough, or difficulty in breathing, and at least history travel of residence in a country with confirmed cases in 14 days prior to the onset symptoms, or close contact with a confirmed or probable COVID-19 14 days prior to the onset of symptoms, worked or attended a healthcare facility in the 14 days prior to onset of symptoms where patients with hospital-associated COVID-19 infections have been reported. A probable case is a suspect case for whom testing of 2019 nCoV is inclusive, or for whom testing was positive on a pan-coronavirus RT-PCR assay. A confirmed case is a person with laboratory confirmation of 2019 nCoV infection, irrespective of clinical signs and symptoms. How to handle a suspect case? Immediately put on your personal protective equipment, PPE. Isolate the patient in a well-ventilated single room and give support care. Immediately notify the hospital, facility surveillance officer, or the infection prevention and control focal person, IPC. The officer will notify the sub-county disease surveillance coordinator and the division for disease surveillance and response, DDSR, through hotlines 0800 721 316 toll-free or 0732 353 435 or 0729 471 414 or 719. The surveillance officer will fill in the outbreak investigation forms supplied by the Ministry of Health. Refer to your video on procedures of a suspect case for COVID-19. Case management guidelines. Adhere to infection prevention and control focal person (IPC) protocols. Limit the number of medical, support personnel and relative interacting with the patient. Any person interacting with the patient must put on personal protective equipment, PPE. Avoid contact with your body parts either through touching or scratching. Designate a special room for medical personnel to change their clothes. Diagnosis for COVID-19. Diagnosis for COVID-19 can be done through positive clinical presentation as evidenced by various signs and symptoms such as fever and difficulties in breathing. Epidemiological link by looking at possible exposure to virus 14 days prior to the onset of symptoms, e.g., contact with a confirmed or probable case. Lab testing. This entails oral pharyngeal swab, nasal pharyngeal swab, serum samples. You must complete the case investigation form for every case meeting the suspected case definition. Each laboratory specimens collected from the suspect cases must be accompanied by its case investigation form. A line list of all cases, suspected, probable, and confirmed, must be prepared and updated daily by the admitting health facilities. Copies of case investigation form and the updated line list should be submitted to the next higher level daily. These two forms help to keep track of infections and recoveries, as well as aid in tracing the contacts. The surveillance team at the county and MOH levels will regularly require the forms to monitor the evolution of the epidemic. Contact tracing. Procedure for conducting contact tracing. A contact is any individual who has been within 6 feet of a laboratory confirmed or probable COVID-19 case for at least 15 minutes. Always prioritize remote communication during case investigation and contact tracing. You should only consider in-person communication after exhausting all remote options available. Testing is recommended for all close contacts of confirmed or probable COVID-19 patients. Those contacts who test positive, symptomatic or asymptomatic should be managed as a confirmed COVID-19 case. Asymptomatic contacts testing negative should self-quarantine for 14 days from their last exposure, i.e., close encounter with the confirmed or probable COVID-19 case. If testing is not available, symptomatic close contacts should self-isolate and be managed as a probable COVID-19 case. If testing is not available, asymptomatic close contacts should self-quarantine and be monitored for 14 days after their last exposure, with linkage to clinical care for those who develop symptoms. When a suspected, probable, confirmed case is identified, all individuals that had a direct contact with the case should be listed using a contact listing form. Afterwards, all listed contacts must be followed up upon every day for 14 days from the day of last exposure using contacts follow-up by the CHS supervised biohealth workers. All contacts must self-quarantine and be observed daily with their body temperatures monitored at once every day for the 14 days. Any contact temperatures above 38 degrees Celsius, cough or difficulty in breathing must be considered a suspected case and isolated immediately. Discontinuation of isolation precautions should be determined on case-by-case basis in consultation with the COVID-19 task force. Health education, community responsibility. For all residents, the healthcare workers should insist on proper conduct to reduce risk of infection, including cough etiquette using mask, tissues, or flexed elbow, avoiding close contact with sick people, maintaining proper hand hygiene, avoiding unnecessary contact with animals, report suspected cases to closest health facility or command center. An alert desk, command center, should be established at national, county or health facility levels with telephone lines, possibly toll-free and manned by a trained team. Disseminate the telephone numbers widely. Encourage members of the public to call in with their concerns. Management of COVID-19. There are no virus-specific prevention or treatment regimens for COVID-19 as yet. So, for the management of COVID-19, every healthcare workers should adhere for the following guidelines. Triage. Recognize and sort patients with severe acute respiratory infections. Immediately implement transmission-based precaution and infection prevention and control measures. Provide cases with early supportive therapy and monitoring. Collect specimens for laboratory diagnosis. Manage hypoxemic respiratory failure and acute respiratory distress syndrome, ARDS. Manage septic shock. Prevent complications. Give specific consideration to pregnant patients. Procedures for primary screening, risk assessment, and referral of suspect case for COVID-19. Healthcare workers of point of entry, casualty, emergency departments, OPDs, etc. should be watchful in order to promptly identify persons that may require evaluation of COVID-19. Healthcare workers must observe standard precaution masks, gloves, gown, dust coat during primary screening. In secondary screening, healthcare workers must use N95 mask with gloves, gown, dust coat. Keep the door for isolation room closed at all times. Manage waste from suspected cases safely. Clean and disinfect the rooms regularly. Clean utensils used by patients with soap and hot water. Patient isolation. Like other respiratory viruses, COVID-19 is mainly transmitted through droplets and contact. On suspicion of COVID-19 case, promptly implement isolation precautions. Place the patient in an airborne infection isolation room, AIIR, or an isolation unit for a group of patients, or, if none available, make use of a private room. An isolation unit housing many patients must maintain a 1 meter, 3 feet, spatial separation between cases. Restricted entry hospital signage. Display a signage at the door to warn other healthcare workers, support staff and visitor on the restricted entry to the room, and as a reminder for those who must enter to wear the right personal protective equipment, PPE. Movement of a patient. In the event that you have to transfer the patient from one location to another, observe the following guidelines. Prior to transfer, keep the patient in isolation room and withhold any non-urgent investigation that would make them leave the room. Provide the patient with surgical mask before they move out of the room to reduce the spread of the virus. Referral of the COVID-19 suspect or confirmed cases to another healthcare facility will be done using an ambulance that is fitted with oxygen and has required personal protective equipment, PPE. Notify the receiving facility before departure. The ambulance must be cleaned before it is used by another patient. Guidelines for a patient in transit for referral facility. The healthcare workers should take standard precaution by avoiding contact and using the personal protective equipment, PPE, to avoid airborne droplets. The driver must wear a mask in case there is a possibility of patient chamber and driver's cabin interacting. Notify the receiving facility in advance. After delivering patient, disinfect the ambulance with an appropriate disinfectant, e.g. enzymatic disinfectant. The enzymatic disinfectant can be used to disinfect planes if the need arises. Disinfectants containing glutaldehyde are also good for disinfecting metallic objects. Home-based isolation. Guidelines. All decisions for home-based isolation must be made in consultation with state or local health department staff. A healthcare professional should assess whether the residential setting is appropriate for home care. Consideration for home care at home include: is the patient stable enough to receive care at home? Are appropriate caregivers available at home? Does the house have a separate bedroom where the patient can recover without sharing immediate space with others? Resources for access to food and other necessities are available. A caregiver may wear a cloth face covering when caring for a person who is sick. However, the protective effects, how well the cloth face covering protects a healthy person from breathing in the virus, are unknown.